Now that we have reviewed how reproduction is hormonally regulated, we can now proceed to how birth control works, which is the topic for lecturette 3. All right, here we go, birth control. Now, I want to start off this lecturette by defining birth control. So birth control is also called contraception. And contra means against or to oppose. And ception is the root word for conception, which is the union of egg and sperm, which is also called fertilization, the forming of a zygote. So a true contraceptive will block the union of the egg and the sperm, so no zygote can be formed. Now, I know that this lecture is supposed to be about contraception, but I am going to introduce the topic of an abortive. And I'm doing it is because it's common to have these two terms mixed up. Now, an abortive, whether it's done using an oral medication or manual removal, is used when a zygote or fetus is already formed. So an abortive is not a true form of contraception. Okay, so now let's talk about mechanisms of actions. And I want to do a short sketch of a woman's hormone cycle. So the y-axis is going to represent our hormone levels, and the x-axis is going to represent time with our 14-day marker here and our follicular phase on the left and our luteal phase on the right. Now, the single peak that I'm drawing here is going to represent LH, FSH, and estrogen. And then this line here is going to represent progesterone. And as a review, for a woman to conceive, she has to have the appropriate amounts of FSH, which matures the oocyte and allows for the production of estrogen, which is needed to grow the endometrial lining needed for implantation. And she needs to be able to maintain that lining via progesterone. And then lastly, she needs an LH surge, which you folks know is responsible for ovulation. Now, once ovulation occurs, that oocyte is going to start traveling down the fallopian tube and is only viable for 24 hours. So let's mark up our drawing here. 24 hours. And this is what we're going to call oocyte viability. And what that means is after 24 hours, that oocyte is going to start to degrade. So fertilization has to occur within this 24-hour window of time. But if fertilization does take place, which occurs in the fallopian tube, it takes about 7 days for the zygote to travel down the fallopian tube to the uterus where it will implant. So this window I'm drawing here, start with day 0, draw a line. This will represent 7 days where the egg is fertilized, but it is not implanted. Okay, now below this line, I'm going to start to review contraceptives. And the mechanisms behind contraception is negative feedback. And I'm only going to present 3 different contraceptive types: a pill, an implant, and a shot. And there's a lot of different newer birth control types on the market, like the mini pill and the NuvaRing. However, I'm not going to talk about those because the mechanisms I'm going to present to you will cover all the contraception available to women that is on the market today. Now, number one, this is the classic birth control pill. And it is made out of a synthetic estrogen and a progestin. Okay? Progestins is a categorical term for progesterone-like hormones. Okay? Now, estrogens cause negative feedback, and you already know this on the HPG axis, right? So it'll shut down GnRH, LH, and FSH, which will result in no LH surge and therefore no ovulation. Now, progestins, like progesterone, also do negative feedback on the HPG axis, which of course is going to result in no LH surge, and of course, therefore, no ovulation. But it also results in a thinning of the endometrial lining. There are also contraceptives that are not oral medications, one of which is called Norplant. And Norplant has some controversy around it, which I don't have time to discuss today, but I believe it has another name that you can look up if you're interested. So Norplant is a progestin implant, and they inject it sub-Q, and it stays there anywhere from 3 to 5 years. And then there's a medication called Depo-Provera, which is a shot, a progestin shot, and you take it every 3 months. And both these medications will block the LH surge, so you don't have any ovulation, and of course, it will thin the endometrial lining. So birth control methods 1, 2, and 3 are taken from day 1 of the cycle, which is day 1 of menstruation here, and they're delivering a consistent dosage of estrogens and progestins throughout a woman's cycle to shut off the HPG axis. Okay, now let's talk about something called Plan B, which is also called the morning after pill, and it is a single high dose progestin pill. Which is taken the morning after, or as soon as possible after you've had, air quotes, accidental sperm enter the vagina. Now, Plan B does 2 things. A, if taken before ovulation, the progesterone or the progestin will inhibit the HPG axis. Okay, so it's going to inhibit GnRH, LH, and FSH. And in doing so, there's not going to be any LH surge. And therefore, no ovulation. So even if sperm is present in the fallopian tube, there won't be an egg to fertilize. Okay? Now, if you take Plan B post ovulation, and the egg is already fertilized and it's now traveling down the fallopian tube to the uterus, Plan B is now acting as an abortive, and it does so by disrupting the endometrial lining so that the zygote cannot implant and therefore it dies. So here, let's write that down. It disrupts the endometrial lining. And this allows us now to have no implantation. But you have to take it before implantation. Otherwise, this doesn't work. Okay. Now let's draw where B acts on our graph. So here, this is number 4. This is plan B. Remember, part A acts as a birth control by negatively feeding back on HPG axis if it's taken prior to ovulation. But if you take it after, this is anywhere post ovulation, it is now acting as an abortive if you have formed a zygote. Okay, now, if the zygote has already implanted, in the early stages of pregnancy, you can take a chemical called RU486 along with a contractive like oxytocin or something called prostaglandins, right? And so these are all binding to smooth muscle, contracting to help you shed the uterine lining, okay? So what RU486 does is it is a progesterone receptor antagonist. Okay, so if you folks remember what receptor antagonist does, it binds and it blocks. And if you block this receptor, you can no longer maintain the endometrial lining. And then what will happen is you will shed the uterine lining, thus terminating the pregnancy. So if you do take this chemical, which is an abortive, it would be taken here after implantation has occurred. The only birth control that is out there for men is condoms and vasectomy. So a vasectomy is an outpatient procedure, which means there's no overnight stay in the hospital. You just clip the vas deferens so that sperm cannot exit the body, and then you can go home. And this procedure is usually reversible, depending on how much scar tissue is present and some other factors based on health. And it's a very easy procedure. It doesn't disrupt male hormone function, and you don't have to have major surgery. Yet, most men don't want to have this procedure. Now, women also have a vasectomy-like procedure. It's called tubal ligation, which is a permanent procedure where women go and undergo major abdominal surgery and cut, tie, or block the fallopian tube so there's no passageway for gametes. Now, over the years, after covering female birth control and discussing vasectomies, I always get asked why researchers haven't developed a male birth control yet, which doesn't involve any type of tube clipping. And I am here to tell you that researchers have developed many renditions of a hormonal male birth control pill since the 1950s. And the reason we don't have one on the market yet is because men don't want to take it, because there are too many side effects like depression, irregular heartbeat, injection site pain, muscle pain, acne, mood swings. This is ringing a bell for many women who are listening to this lecture right now, because I'm here to tell you that these are all side effects that many women endure while on hormonal birth control. In fact, women suffer from more birth control side effects than men do. For example, other common side effects that women experience on a regular basis of taking a hormonal birth control are nausea, headaches, weight gain, mood swings, blood clots, blurred vision, seizures, and heart conditions. People, seizures and heart conditions, okay? Yet, women are the ones that bear that weight to take birth control. There are many gender inequalities that exist in our world today, and the burden of birth control falls mainly on females. Here's another example that illustrates the reproductive inequalities between men and women. In the late 90s, a man was convicted of raping multiple children, and he was in jail. And when he came up for parole, he was asked if he still had inappropriate sexual urges towards minors and would he rape again. And this convicted felon said, yes, I will act on my urges. Now, when this convicted sexual offender was about to be released on parole for good behavior, he pleaded the court to mandate chemical castration by giving him the Depo-Provera shot. And you folks know that giving a man a Depo shot would shut down his HPG axis to where his testis would decrease testosterone production and then therefore decrease libido, which has been shown to lower the risk of sex offenders committing new crimes by 500%. Now, the courts denied his request for the Depo shot and deemed chemical castration cruel and unusual punishment. So it's okay for a woman to be chemically castrated via the Depo shot, but it is cruel and unusual punishment for a male sex offender to be chemically castrated via the Depo shot. And this is the type of social and gender injustice that's happening all around the world. And it is paramount that the human race change how they think about birth control and be open to new medical methods and change socially how we think about gender roles so that we can both allow men and women to take an active role in family planning. Now, I do want to say that there are some men out there that do take an active role in birth control and are very conscientious about the inequities, right, between birth control between men and women. And they get a little offended when they hear this part of the lecture because they report back to me and say, but I take an active role in birth control. And if the shoe doesn't fit, please don't wear it. Please stop shoving your big feet into a small shoe. Okay. If you take an active role in birth control, then this doesn't apply to you. But I have to be honest, I am a reproductive endocrinologist, and generally speaking, worldwide, majority of the burden does fall on the woman. Okay. And this is something that you folks as healthcare providers, kinesiologists, as therapists, as you folks move forward, it is very important that you folks understand this concept. Okay. All right. That's it for lecture 3. Much love to all you reproducers.